Greetings, everyone. This is Eric Laser, and welcome to Bright Spots in Healthcare, produced by Bright Spots Ventures. We bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare organizations across the land. We do this because we want to identify as many of these bright spots, these ideas, these successes at organizations across, so that you could potentially determine if they are warranted to bring into your organization. We want you to be able to apply these at your company if they could be helpful. We believe this approach of finding bright spots and cloning them is the most effective strategy to improve healthcare in our lifetime. If you haven't already subscribed to the podcast, every live episode that we're doing right now, recording live via webinar, gets dropped into the podcast feed 5 days later. We also do a number of record-only episodes. We get access to all the great insights from leaders in our industry, your peers, each and every week. So I encourage you to go to wherever you listen to the show, Spotify, Amazon, Apple, wherever, type in Bright Spots in Healthcare, you'll find us there. We have an incredibly topical, important issue to discuss today, and that's sort of how health systems are using AI to strengthen financial resilience, especially in light of a lot of the changes that are affecting all of you. So we have a lot to cover today. We're really excited about the guests we have. Our sponsor today is Navina. If you haven't heard of them, we bring in our sponsors and our partners each and every episode to bring in insights and expertise. They are a AI company. They have an AI co-pilot that transforms the way practitioners interact with patient data so they could truly understand every patient and deliver the best possible care. They support care teams, practitioners at every touch point, reducing the administrative burden, improving clinical outcomes, and helping all of you succeed in value-based care and create some more financial resilience, which is especially pertinent in light of some of the new policies coming down the pike. You could check them out at navina.ai. I'll tell you a little bit more about them later on during the episode. Our guests today from Navina, Andrew Bean. He is the Vice President of Customer Success at Navina. We have Rebecca Welling, the Vice President of Risk Adjustment at Intermountain Health. And we have Shaker Ramanathan. He is the Executive Director of Digital Transformation at Atlantic Health System. Thank you all for being here. I know that AI, we should all know at this point, AI is just not going to be a buzzword that's going to go away. It's becoming all-encompassing in all of our lives. And as it relates to healthcare, it's becoming a vital lever for health systems, medical groups, MSOs, to stay financially resilient. It's a tool for them to improve outcomes, but also improve financial health. And so today's conversation, we've divided into 3 segments. First, how health systems are using AI to improve practitioner bandwidth. Second, how they're applying AI to close gaps in care and improve quality. And finally, we're going to talk about how to make AI tools work in the real world through successful implementation and things to kind of look out for where people have already kind of stumbled and try to save you that time. So we're going to kick things off with practitioner bandwidth. And so Shaker, I want to start with you. And if you can walk us through how Atlantic Health System is using AI in this area to help physician bandwidth and contribute positively to the system's balance sheet.
Yeah, no, absolutely. And I mean, I think one of the biggest benefits of AI in healthcare is really being able to help clinicians with a lot of the administrative burden that comes with just practicing medicine today. And the ability to really kind of then leverage kind of some really kind of augment their work with some of the AI tools so that they can spend more time with actually taking care of patients and doing the things that really they signed up for when they got into healthcare. One of the things that we're doing that's really kind of exciting is, we have a program around really kind of putting out a virtual MA for a number of our primary care practices and some of our specialty areas where we're really trying to be able to kind of engage patients in a more interactive kind of way. It's an app that patients can download. Somewhat acts as an extension of the practice. Where they're able to ask things like, hey, what was my lab result, and have an interaction on being able to understand not only kind of, hey, this looks like this was slightly elevated. What is this about? It may be normal from a clinician perspective, but from a patient perspective, they may have questions around it. They may be understanding it looks like it's slightly elevated. Is that something I should be concerned about? Most of those questions that would otherwise take a lot of either clinician or practice time to be able to answer, to resolve, allows the patient kind of 24/7 access. So you're getting better overall patient experience, as well as you're kind of decreasing some of the burden that would otherwise be coming to the clinician. We're seeing a lot of great success. We're seeing about 86% of the messages are being able to handled by the AI itself. 7% of those get escalated to the practice. So a medical assistant, front desk staff person, and another 7% that's actually going to the clinician itself. But that means the significant majority of that is really being handled by the AI.
Okay, so 85% of things are taken care of. The other 7% at least just go to the frontline staff at the practice. Providers are down to 7%, where they have to deal with 7% of the issues. Could you, just for context, Shaker, like give folks who aren't like in the Northeast or in New Jersey, New York, a little bit of like an overview of the scope of Atlantic, just so people could get a sense of like how big your ACO population is and things around that?
Yeah, so I mean, we're a 8 hospital, about 500 sites of care. Our ACO population, so our value-based care population, is about 500,000 patients. We overall kind of primarily based in New Jersey, with a little bit of New York, Pennsylvania kind of mixed into that. But for the most part, kind of northern New Jersey is kind of where we're based.
Am I Epic for most locations?
Epic across the board as far as an EHR goes, as with many of the large health systems.
Got it. Great. All right. Folks, also, one thing I forgot to mention, we will be sending you, another email, I know, at about 45 minutes past the hour, just asking not only for your feedback on how we did today, but equally as important, what other content we should be covering throughout the rest of 25 and into 26. That's right. We're already planning Q1 programming. And so it's a 2 to 3 minute survey, and we always beg all of you to take those 2 or 3 minutes. And what we'll do as a thank you for doing that is we'll send you a copy of all the notes that I've taken during today's episode. I'm pretty good at taking notes, and I think I'm still better than AI. So we'll send those to you as a thank you if you complete the survey at the 45-minute mark. Thanks in advance. So staying with the topic of clinical bandwidth, and so InnovaCare, which is an organization, if you're not familiar with them, down in Florida, they operate 37 clinics. They are always innovating and looking for ways to scale and be more efficient. So I'm going to bring in Andrew Bian, who is head of customer success at Navina. You're familiar with Innova, Andrew. How are they squeezing out more production they have about 150 plus providers. How are they squeezing out more production, enabling those providers to be more efficient without adding hours to their workday?
Yeah. So InnovaCare took a little bit different approach, right? I think some folks are trying to squeeze the lemon as it relates to how do you get providers, clinics at the point of care doing more within it? Is there a way to extend that? Can you leverage support staff in a different way? And so what InnovaCare did is they actually deployed a pre-charting workflow whereby the support staff can actually take a look at what the results of AI has done ahead of time. So we're talking about even 7 days out from the encounter, clinicians are able to take a look at those insights. It's twofold, as to what happens with that. There's a communication component where the support staff is able to communicate what's been happening with that, what's the result of that look. But then also it's working up suggestions so that when the provider is seeing the patient at the point of care, they know exactly what to do. It's all in the name of efficiency, right? If there are things that we can do to help clinicians out, whether it's at the point of care, prior to the visit, after the visit, I know that's of interest to folks. So in this case, that pre-charting there and that workflow enabled them to actually do what they do best, which is see more patients. So in this case, they were able to, on average, see another 1.2 patients per day as a result of embedding this workflow into their operations. So a pretty significant impact.
So pre-chart review, determining how to properly triage, fits into the clinician's workflow. We'll get into more of that later on. And all of a sudden they're seeing an extra almost 1.25 patients per day, which is obviously additional revenue for everyone.
That's exactly right.
And
Yeah.
a better patient experience, right? Because now you're getting more access, more appointment times.
Exactly. And you know exactly what the patient needs, right? And there's been clinicians that are looking at information and it's presented to them as a clinician would do that, right? So it resonates, but also using the same type of language and evidence that you would expect.
Great. Let me move back to Shaker. And by the way, quick PSA, folks. If you have a logistical question, definitely use chat. If you have a comment, you could definitely use chat. But if you have a question for any of our guests, my team and I are monitoring the Q&A module. And just because we've done this a long time, it's much easier for us to manage the ongoing back and forth with all of you using the Q&A module for questions for our guests. So I invite you to do that. If you're using sort of at least a PC laptop, sometimes you have to click on the three dots on the far right that say more to open up the Q&A screen there if you don't see it in front of your interface. So Shaker, beyond the AI medical assistants that you mentioned, what are some of the other initiatives maybe worth flagging for the audience that are helping improve provider bandwidth at Atlantic?
Yeah, so I think one of the big things a lot of folks are really interested in that we're doing a lot in the imaging space. I think a lot of organizations are we're using some of the AI tools to really help with prioritization, especially being able to look at images, understand kind of the acuity of those patients, and being able to make sure that the right patients are getting seen at the right time. I think traditionally, otherwise, radiologists are kind of focused on more of a first in, first out type methodology. But then you get that patient that's coming into the ED with a brain bleed that needs to be seen right away. How do you kind of close that gap? And how do you make sure that the right type of patients are being seen, which we're not quite at that point of where we're necessarily able to reduce the number of radiologists or anything like that. But at the same time, we're able to get that initial read, we're able to save them time, we're able to make sure that the right patients are being seen, and then being able to kind of tackle more complexities, more different kind of patients and those kind of things, and as well get a higher level of accuracy. Then also, when we start looking at things like clinical documentation integrity, right? So when we start looking at how do we make sure that the work that the documentation that's in the chart that the provider's doing and the diagnoses and things that they are putting on the patient's problem list that are part of the encounter, that they're actually matching up to the actual work that they did. And so being able to look through all of the documentation, make recommendations as far as, hey, did these were additional things that you should have potentially been considering. And then working kind of with our nursing staff to be able to look over that, make sure that those are kind of the right things, and then kind of work with the providers to make sure that we're capturing the right level of coding, we're capturing the right level of documentation, all of those type of things, and really reducing that administrative burden that otherwise would fall on the clinician.
Okay, let me summarize some of the tools we've already gone over. So Atlantic's got an AI medical assistant. They're looking at sort of what are you calling, like an AI radiologist, where you're helping prioritize the imaging for your or AI radiologist assistant. who's helping triage the radiologists, and you're also working with clinical documentation. InnovaCare, and folks who are asking, by the way, tell me, Andrew, keep me honest. INNOVA, I think it's capital C when I looked them up, CARE.
You got it.
They are 37 clinics, 150 plus providers, by the way, for those of you asking. They're using Navina to do some pre-chart reviews to create scale and triage so that clinicians are actually able to see an extra patient 0.2 on average per day. So 1.2 additional visits per day per provider. Got that right so far?
Yep.
That's a quick summary if you just joined us late. And so let's real quick, I want to bring in Rebecca out in Utah at Intermountain. But before we do that, we've got a really busy summer and fall for you with all kinds of great content, mostly suggested to us by all of you. So I wanted to give folks a quick little preview of what's coming down the pike the next 3 or 4 weeks and give you an opportunity for us to register you guys to attend these things and be like a little bit of a concierge for you. So next week, we're also doing another specific provider program for leaders at providers about how to close gaps at scale using digital technology and smart digital clinical tools like remote primary care. We already have the president at Tufts Medical Integrated Network on. I've already met with her to prep. She's unbelievable. She's got a lot of great stories. We got the VP of Clinical Management at Health First. So we get a health plan perspective. They're more of an integrated delivery system in New York City for the Medicaid population. And we also have the Associate Division Chief to the Group for Clinical Innovation at Rush University Medical Center in Chicago. So that's going to be a great show. Then on a special episode we're doing on a Tuesday, which we rarely do, actually. We're going to be covering Tuesday, July 29th. We're going to talk about the new growth playbook for the changing healthcare market, right? A lot of you, especially solution providers in the audience, know that things are going to change in a hurry, and the traditional way of marketing and sales is going to be less effective. And how do you start thinking more strategically about how to build and grow your business and forge these partnerships and collaborations? And we have chief marketing officer, chief revenue officers at leading solution providers across the country coming to join me for a discussion on July 29th. That's going to be fun. And then on August 7th, we're talking about Medicare stars, which is also timely, and using stories to drive star ratings around medication adherence. We're calling it Lights, Camera, Adherence, and that's on August 7th. And then finally, on August 14th, we're talking about engagement and personalization through missed data, missed dollars, and how member insights are helping create risk models helping create models, that risk models are blind to. So how to offset what's being missed by all of you if you're an ACO taking on risk. And that's going to be an incredible conversation amongst heads of quality, operations, and engagement health plans. So you could click on any of those 1, 2, or 3 if you want. You're allowed to click multiple times there. If you want us to register you, we'll put up that poll. All right, Rebecca Welling, Vice President, Risk Adjustment, Intermountain Health. Let's start talking about shift. Value and outcomes, and how is Intermountain improving clinical quality results and better closing gaps in light of all the tools that are being put in front of you?
Awesome. Thanks, Eric. Sure. So Intermountain is actually looking at quite a few AI tools, and I'll discuss those as I go further into the presentation. But the one that I wanted to talk about right now was that Intermountain is a multi-payer system, meaning they've got their own health plan. They've also got multiple other payers that they're working with. They're on value-based contracts. Thus, the risk adjustment that they need to do is pretty darn important for all of those different payers. They've got multiple lines of business, meaning they've got Medicare, Medicaid, the Affordable Care Act patients, as well as ACO patients. So all of those different populations are risk adjusted. Anything that's federal is going to be risk adjusted. And so they needed a tool to try to ensure that they were capturing the adequate risk of their population. It's been kind of a 3-pronged approach, starting first with a retrospective, doing it in the back end, trying to clean up what wasn't done in the first place. But then decided, hey, we need a tool that we can put in place, point of care, that we can serve up, gaps of care to our providers as they're seeing the patients. And then after the visit has happened, another point of care tool there where they could do a concurrent review and make sure everything that the doctor had documented, all the CDI was correct, and that it was dropped onto a claim correctly. So both of those three processes, we deployed an AI NLP type solution. So far, the retrospective tool has been in place for multiple years, which I think most payers and a lot of health plans have in place. The pre-visit tool will go live with us. So I can't give you results on that, but so far it's going pretty well. That will go live with our implementation of Epic. We are moving from Cerner to Epic, and that happens in September. The post-visit tool did go live about a year ago, and that's what I can share with you. That post-visit means after the visit happened, the AI looked at the medical record and said, here's areas where we think that there's additional opportunity that you didn't actually put on the claim that's going to go out. And here's areas where you actually put something on the claim and we don't agree with it. Just have a CDI specialist look over this and make sure it's correct. We saw just about a 20% increase in productivity just within 6 months. There were probably 121 counters that went right through the AI and said there's no need to have a physician or anybody relook at this. It's done perfectly. Saved a lot of time there. The number of chronic conditions that were captured went up almost 158%. But in addition to that, the number of chronic conditions that had been captured that should not have been, or the documentation didn't support it, also was captured at about 140% increase from what we had done manually. So there was some tremendous results there using the AI to scan the chart note prior to actually going on a claim. The pre-visit tool, as I mentioned, will go live in September. Lots of work's been done there, and essentially it will scrub the medical record using AI to kind of surface what opportunities there are that may not be as obvious by looking at the chart notes, looking previous chart notes, looking at labs, looking at, medications, and saying, hey, it looks like this patient might be being treated for this condition that has not been identified or was identified elsewhere. And for those of you that are familiar with risk adjustment, know this all has to happen every single year in the calendar year. And so we've seen significant progress since we've started putting these tools in place.
Yeah, this is a great topic to stay on a little bit, because I know there's a huge opportunity for everyone in the audience to automate and bring in AI. Both it'll help your quality scores and your revenue, right?
Right.
Risk adjustment. And now with the audits going on, like, it'll probably keep you out of trouble there too. I don't want to get ahead of it.
Absolutely.
So, Andrew, I know you are very familiar with Privia. If those who are not, you probably all are, but 1,200 locations, over almost 5,000 providers. How are they approaching data integration challenges and everything around fragmented data and solving for gaps in care, sort of like Intermountain is?
Yeah, it's a very similar story, right? The same problem they're trying to solve for. It started with, how do we differentiate between data gaps and actual clinical, actions that need to be taken? And it started with getting data in one place, but then more importantly, what are you going to do with it? And how do you make it actionable for those that are at the point of care? Rebecca rightfully pointed out, there's the pre-visit aspect of this, there's the intra-visit, and there's the retrospective piece of it. Privia was also looking to solve for that in a similar way. And the way that they did that was, through use of AI, is to have, the information landing in one place, which includes not only the clinical chart, but also HIE information, claims information, could be other disparate data sources. Make sure that's in one place, but the AI is running on all of that. So it's not only scrubbing the chart, it's not only scrubbing, encounters and information coming from the HIE, but it's putting that all together into the right story that's contextualized for the individual patient that can then be utilized, whether it's support staff ahead of time, even the clinician ahead of time, intra at the time of visit, and then of course after the fact as well to make sure things are tidied up. So Privia wanted to solve for that problem. They had some information living in different places, bring it all together, run the AI on top of it, and then present the right information, that is contextualized for individual patients at the point of care.
Stuff. I want to try to take as many questions as I can from the audience. And there's a bunch coming in, so everyone listening is doing a great job here. I'm going to start, Shaker, with you. I want to go back to the AI assistant. So Eliza has two really good questions. One is the space is using AI assistant for point of care efficiency, but it's very crowded. What is the differentiator that you look for when you made the decision to bring in, your partner?
Yeah, absolutely. I mean, I think one of the biggest things is like integration into kind of clinician workflow. We want it to be an extension of the practice, and some of this is really how we're not just like deploying the technology. We're rolling out the technology. We're working with the clinicians. We're making sure that they're kind of buying into the what the technology is doing and how it is really kind of augmenting their practice. And then also kind of spending the time to make sure that the patients are onboarded, and ultimately that the practice is buying into this whole thing, right? And we needed partners that are flexible, who understand kind of the problems that we're really kind of trying to solve for, not just kind of selling a solution. And kind of we went through a lot of co-development process to really kind of understand, these are the type of problems that our patients are asking, that are burdening our physicians, and how do we kind of solve for that? That's going to be somewhat unique to every health system, every practice, and being really able to kind of address those needs, and truly being a partner and not a vendor.
And what about, same question for you, sort of, Andrew, that was asked, is sort of what makes Navina's solution superior or different from what's out there?
Yeah, I think one of the key differentiators is it's one thing to have all the information in one place, but is it trustworthy? I think I saw something also in chat about, if you run into issues with AI generated claims, coding, information that, stirs up even more of the audit trail. One thing that helps Navina stand apart is that for every suggestion made, it's not strictly a accept button. It's already leading you to that answer, right? It's accept, reject. You can hold on to it. There's decision making that's still made by the best person to do that, which is the clinician themselves. But more importantly than that, in addition to the insights that are generated, the evidence behind it is already there. So it's not just suggesting a diagnosis or a quality gap that needs to be addressed. The evidence to support the suggestion, but also the actionable insight as a result of that, is right in the UI. So I don't need to hunt around anymore. It's already there, and I can trust what I'm looking at is accurate.
All right, let's move on. I want to get into clinical care. It's actually, though, a good segue that you gave me there, Andrew. First of all, if you joined us late, and this will be like sort of the last plug I give my partner Navina here, but they are a clinician-first AI co-pilot for value-based care, and best in class for clinician, KLAS, by the way, for clinician digital workflows. And they're really good at just what Andrew alluded to, taking fragmented data and putting it into actionable insights right at the point of care. And their co-pilot helps improve risk adjustment, quality metrics, and your overall population health, but also helps reduce the workload, the administrative burden. And they've earned the trust of over 10,000 clinicians and care team members across over 1,300 clinics, and all kinds of big name value-based care organizations like Privia and Millennium Physicians Group and Agilon. Check them out at navina.ai. The one thing I wanted to do, because I was prepping for this, and the Jefferson Medical Group, another well-known health system, they implemented Copilot, Navina's AI Copilot, to support their complex contracts. And it went so well that the American Academy of Family Physicians actually did a study, and they released the study, and it was co-authored by doctors Stephen Waldron, he's the Chief Medical Informatics Officer at AAFP, and Dr. Edmund Billings, who at the time was a member of their AAFP's Innovation Lab. And what I really liked about it was there's a lot of really good charts and data. It reminded me of the USA Today, which is my favorite sports page back in the day when we used to read paper when we were on the road. But it talks about, it's a real good blueprint if you're interested in how to integrate AI into your clinical workflows. And we're going to talk a lot about that in a moment around implementation and how Jefferson achieved some unbelievable results, including five-star ratings for their Medicare for colorectal cancer screening. So if you want that study, I could get it to you. My team will, or I will. It's a 13-page report, but I guarantee you it's really only about 2 pages of text, and it's mostly pie charts and cool stats. We'll send that out to everyone, so you have a little bit of a take-home gift and a blueprint on how to implement things effectively. And if you're listening on the podcast, we'll put a link to email us or request this piece so you're not left out either. But we'll do that. Let's move now to clinical care and bring back in Rebecca Welling, who's running risk adjustment for Intermountain. Rebecca, do you have another example to kind of build upon using different technologies to integrate with clinical that has a clinical and financial impact that you could provide an example for?
Sure. We've just gone live just about a year ago with a solution to help us with malnutrition. So often our patients that had malnutrition were not being surfaced because the practitioners did not have the time, either those or the dietitians, to go through all their medical records, look at what these patients had and make a determination. So there were people that were slipping through the cracks that had malnutrition. So we brought in a solution that actually scans our medical records at the end of every day and then highlights those ones that are potential malnutrition patients that need further care, and then serves it up to the dietitian, serves it up to the practitioner, and says, we believe this patient is showing signs that they're going into a state of having malnutrition or already should be diagnosed with it. The other issue we had was that the correct ICD-10 codes, as well as some of the CPT codes to treat it, were also not being put onto the claims, and so it was going kind of under the radar. This solution also helped in ensuring that the correct coding was happening. The members were surfaced, and we saw just about a 25% increase in the number of patients we had that had malnutrition. Not necessarily new. It wasn't that they were, we discovered patients that we were already treating that were at that stage based on the criteria that was within the solution, which was, and it was true, it was very helpful. It's been a pilot. We are taking it live to our whole population now, but within that pilot, it was very successful. The roadblocks being just the IT resources to get it installed. You know, if you're an Epic shop or even a Cerner shop, it's often hard to get these bolt-ons put in, and that was a challenge for us. But now that we're up and live with the pilot, where it will go live with our whole entire population in once we go live on Epic in September. So we saw really good results with that. And all of that was done by AI. None of that was my manual chart review. It would serve it up, and then we'd have the clinician actually review it and either agree, say, yeah, this looks like we need to move forward and give this patient more treatment. Here's everything we need to get it going. Here's the codes, the CPT codes, the ICD-10 codes, and then use that to move forward and ensure that those care gaps were being closed on malnutrition.
So it's helping you, obviously, cardiometabolic, all kinds of patients. It's also allowing you to potentially maximize your codes because you're adding in these services. So you're doing a couple of things. You're taking better care of the patient, especially if it's chronic illness. You're coding correctly to maximize the funding that you're earning from taking care of these individuals.
Yeah, but even more importantly than just the funding, we're identifying earlier those members, patients that actually need treatment. We are working with that vendor to build the tool out to look at more things like CKD, some of the dementia, other chronic conditions that are emergent that we haven't been able to before without someone doing a full record review. Or, you know, if our physicians are moving through these patients so quickly, they may not have the time to look at all of the labs to the level that we need them to. So this is giving us a chance to surface those conditions from a clinical perspective.
Are you positioning the proactiveness with the patient as part of the clinical data that you have on them, your predictive analytics engine? Are you outlining that you're using AI tools? Like, how are you
Yeah,
using the outreach to them?
the outreach. Well, so right now it's looking at all of the chart notes, both structured data and unstructured data that's within the EMR. When you say outreach to the patients, I think once that it's been identified and then we tie it up with the upcoming appointments, then we know, okay, we've got Sally coming in and we're seeing that, you know, these are the clinical indicators that she may be switching into a malnutrition state. So it's more of a tool just to help the practitioner in their identification. And then what's the next steps on how I treat this? Who do I take them to? What do we need to do from here to ensure that these gaps are closed? And because we're a value-based entity, we're going to want to get upstream of so many of these chronic conditions that having a tool to help us do that is not only better for the organization, it's better for the patient.
Love that. That's great. Folks, one quick interjection here. So a lot of you know us as we Bright Spots in Healthcare. We're a podcast webinar company. We actually do a lot more than that. Our mission is to build meaningful relationships in healthcare to improve the quality of the entire industry in our lifetime. And so we do a lot of private events through virtual private events, interactive. And one of the things we want to do on August 13th is bring together folks to talk about AI adoption for value-based care. So right on topic, right? And we want to do, it's a private event. We're bringing in about 8 or 10 folks and I'll facilitate it. And we're going to share ideas. Now, this is only for MSOs, medical groups, and hospitals. So it's if you're a solution provider, you won't be eligible for these. There's no cost to participate. But we'll be doing one on August 13th for an hour. It's called the Private Interactive Roundtable. It's one of the things we do. We don't usually promote them during our shows, but we figured we'd try today because the topic was so overlapping. We have another one, separate topic on specialty value-based care and discussing anyone who's using MSK and doing risk-based arrangements with MSK, how to take that MSK model that may be working and use that as a blueprint for other areas like nephrology or oncology. So we're running 2 of those private events, one on August 13th, one on July 23rd. The July 23rd events for health plans and TPAs. The August 13th event, which is probably most relevant for all of you listening, is for MSOs, medical groups, and hospitals. So if you want to be RSVP for those, let us know. We'll put up a poll. Andrew, I want to stay, Rebecca brought us closer to the patient in our discussion here. And so I want to stay on the front lines at the bedside, or at least at the clinic, and maybe share an example of how artificial intelligence is helping practitioners deliver better care in the clinic, or at the bedside.
Yeah, sure. I think the example that comes to mind is, take a 65-year-old patient, Joe, comes in to see the primary care provider, but what happens between those visits? So now he's coming back, has something like diabetes with other complications, could be CKD, could be otherwise. How does we'll just say Dr. Miller, how does Dr. Miller know what to do with Joe in that instance, right? He's been seeing him, but there's things that happened in between those times. He's maybe doing his best to see him on a quarterly basis, but he's been to the hospital or he's seen the endocrinologist, he's been other places. How is that holistic view being served up to Dr. Miller? And if it is, what's the next step that he knows he needs to take so he can take the best care of Joe? What AI is helping to do is not only bring all that information together, but actually help suggest what are those next steps, which starts with having an accurate condition or an accurate diagnosis for Joe. What Dr. Miller may not be aware of is what's the last EGFR. Now you have that result right in front of your face. It came from an external source, but now it's highlighted and now I can see it. That's the evidence that I was kind of speaking to before. Those vitals and lab results, imaging results are all being brought to Dr. Miller in an easy to understand way, but put together in a holistic picture. So now I know how to take better care of Joe, but I also know how to capture those accurate diagnoses and close those gaps in care.
Love that. And just quickly, providers are just, I know we're going to get into implementation and provider buy-in, but just as a preview, how did you get the providers just to get excited about this?
Yeah. I think show and tell, right? It's all about showing them how it works within their workflow, how easy it is to use. Can I trust what I'm looking at? Some of that has to come with experience. You know, when I'm seeing those suggestions and I'm looking at the evidence behind it, now I trust what I'm seeing. That creates buy-in. Like anything else, there's a change management process. Do you have some other, champions that can help encourage others to do that? There's other operational levers, but I think it really starts with trust and the simplicity of the UI, making it easy to do.
Yeah. Simplicity is the ultimate sophistication. It's one of my favorite quotes. I'm gonna, before we get into implementation, which we sort of just did there, I want to take another question from the audience. You guys listening right now live are doing a great job helping me co-moderate. I'm gonna start with you, Rebecca. No, I'll start with Shaker because I see you might have been typing in an answer to this question, and then I'll come to you, Rebecca. And Andrew, if you want to jump in after that, let me know.
Sure.
Shaker, have you encountered any challenges or concerns where AI-generated billing or documentation led to a claims issue, such as upcoding, inaccurate billing, or a denial, particularly in cases where the coding did not accurately reflect the services provided and may have exposed your organization to another headache?
Yeah, for us, there's always a human in the loop, right? So there's always somebody reviewing that information. The idea is the fact that the AI is really it's making recommendations, it's surfacing information so that it's easier to find the right things and saying, you know what, it looks like maybe you overlooked these three things, or here's additional information that you should be considering. It's not making the decision for anyone, but it's making it so that it's much easier to make an informed decision.
Got it. What about for you, Rebecca?
Yeah, I would agree with Shikar that there's always a human in the loop. For the risk adjustment tool that I was speaking of earlier, that one is looking both ways. So it's not only saying here's additional conditions that the member may have or the patient may have that you haven't coded, but it's also saying here's what you did put on a claim and we don't look at it again because the documentation here doesn't seem to support that, or there's, there should be more evidence. So I'm agreeing that there's always a human in the middle. On the malnutrition situation that I talked about earlier, that one also isn't automatically diagnosing this. It's saying, here's what we're seeing. We're scanning 100% of your patients every day. Here's the ones that are looking like they have an emergent issue. It certainly is not diagnosing them. That still comes back to the provider.
And Andrew, do you have anything to add to that for the MSOs and medical groups around the country you work with?
Yeah, I would say it's consistent, right? There's a human element to this, and I think the one-liner I would say to that is the AI is there to enable efficiency. It's to enable folks to know where to focus and take action on it. It's not to completely replace.
I would even maybe compare it to Chat GPT. If you're using that, hopefully you're not copy and pasting and sending it out. Someone is looking at it and saying, does this actually make sense? And is this real?
All right, let's get into execution and implementation, because I think strategy is worthless without really good execution. And so, Shaker, when it comes to clinical tools that we're talking about, and obviously I alluded to it, or I didn't even allude to it, I said it flat out, you need clinician buy-in, you need training. How are you guys thinking about that, and how are you addressing this as you rolled out, let's say, the AI medical assistant that you talked about earlier?
Yeah, no, absolutely. And a lot of this is like working very closely with the clinicians, with really understanding what problem, what outcome that you're really trying to achieve. I think a lot of the AI tools that are out there is very they're really very much kind of shiny object, really cool things that they can do. But then you need to make sure that you're not trying to squeeze technology and finding a reason to leverage the technology, but you're really kind of understanding kind of the business outcome that you want to achieve, and then kind of working backwards from there. Working closely with those, clinicians, operational folks, understanding that problem, and then really on the implementation side, making sure that it's actually truly integrated into the workflow so that it's not another thing that somebody has to go and do, another application that they got to open. It may sound really cool, but then when it comes down to now you're seeing 20 patients and you've got to figure out how do you get to the next one, your focus is how do you remove a lot of that friction, make bring the right information at the right time to the right person, the right provider, right? So doing those kind of, and a lot of that means that you got to kind of somewhat slowly roll some of the stuff out. I think there's kind of people pilot, and then especially in the AI space, there's like pilot purgatory of, a lot of just kind of, it becomes really difficult to scale because once they've done the pilot, they're looking at that as saying, okay, now we're just going to go from 10 providers to, 1,000 providers. You've got to you've got to spend just as much time as you did in that initial group to get the buy-in, to get the workflows right, and to keep on expanding.
Exactly. And I would say, and I get the privilege of talking to a lot of different organizations. So provider buy-in's a big problem or a big potential hiccup for everyone implementing new tech, especially as it relates to clinical technology. But also, it has to do with workflows. And you could get great technology that works to solve a solution, but if it's not in the workflow, you're done for. And so I want to go back to Privia because it's such a big organization. And Andrew, if you could come back in, like, what did you guys do with Privia to ensure that that implementation system-wide was successful and there weren't they didn't spend all this time and resources to implement, let's say, Navina, and then no one really used it.
Yeah, I think it starts with organizational planning, right? You don't want to go big bang on something unless you've got it figured out, and so it's refining some of those workflows if necessary early on. So what Privia did, which was in a great way, they've organized their organization quite well for having the complexity that they have across nationwide, right? Several states, different clinics within those. They started with a couple markets and said, let's figure this out. Let's create some champions so that it's peers telling them why the workflow is the best way to go about it. There's standardization with flexibility. The tool allows them to do that, but Privia decided this is the workflow we're going to employ, and we're going to train based on that. So it's a partnership, and it becomes hearing it from folks that are already using and finding value in it that helps to demonstrate why that workflow is going to be successful. And Privia found that to be the case. They expanded from that single market to multiple markets thereafter. We're talking about onboarding hundreds of providers every single month, yet they were able to maintain that level of engagement that they expect. We're talking over 90%, while they were still expanding. And this is adoption from day one, not adoption 3 to 6 months in. So tremendous success even early on, while adding tons of docs to a new tool.
So this is important. And if those of you are in tech or listening to this, if those of you are not, I'm going to kind of, because this is a common approach with software, but there's typically folks who are in charge of UAT, user acceptance testing, that are just trained to do this. And here you don't have that luxury. You got to have your providers and your care managers actually being your UATers. And so you do need to roll it out in sort of like, I know pilot purgatory shaker, but there's a balance, right? So you do need to roll out your UATs and different practices like Privia did to make sure the workflow works, the modifications can be made, and then you go live with the whole thing. One more question about implementation, and then I want to get into some innovation, and I want to talk into some pricing models too, from a question from the audience as we get here the last 12 minutes. And by the way, your survey, folks, if you're listening, has already arrived in your inbox. So please, while listening, take a couple of minutes and provide us your feedback. So Shaker, we've been talking about system-wide impact. We also know that AI doesn't have to be like one size fits all. And so I'd love just for folks who are a little bit, they haven't they're a little bit behind maybe you guys in the journey of implementation. Can you share an initiative that's maybe helping a particular subset of providers that surprised you, and why maybe it's working for some of them, but not all of them, and why that actually is okay?
Yeah, no, absolutely. Well, I think a lot of the AI tool, not even just AI, a lot of digital technology in general, right? It's never one size fits all. I think ambient voice is a great example of something that for a subset of clinicians it has been truly transformative, right? So I'd say, about a third of our providers that have kind of used the technology, the feedback is just amazing, right? You get the, hey, now I can finally, eat dinner with my family, and I can, like all that pajama time, all that time that they were spending in terms of documentation, in terms of being able to catch up after the fact, just completely transformative in terms of kind of their workflows and their ability to spend more time with their patients, interact with them more face to face without kind of having to sit there behind the laptop, increases patient satisfaction, the provider satisfaction, all those kind of things. I think one of the things that we've also recognized is the fact that it's that impact is not equal across the board. I'd say it's probably a third of, truly being transformative, a third of those patients or a third of those providers where it's helpful. They like the tool, they're using it, but they're not using it for every patient. They're using it where it kind of makes sense. And there's probably a third of those providers who are actually just, they were really good with their existing workflows, right? They had spent a lot of time building out those templates and macros and things, and they can navigate the chart without really, really thinking about it too much. Their impact is somewhat marginal, and these are not cheap technologies, right? So it's like, how do you then make sure that you're identifying that, like, especially that top third, and how do you make sure that we're getting the tools in their hands? But what we realized was it's not always the most like tech savvy folks. Actually, quite often it's the opposite folks, those people that missed having, kind of scribes in their office and, the ability to kind of recreate some of that experience. Those folks have seen, a tremendous positive impact, but it's like we want to be able to truly understand, who these technologies are really helping, and who they're, it may be a really cool thing to be able to kind of show off, but it's not something that's actually at the end of the day making an impact to the way that they're practicing medicine.
Yeah, what I found interesting when we were preparing and you told me that story is, my quick think, stereotype, typical, like trying to stereotype the whole thing is, okay, your early adopters and your younger tech savvy group of providers is going to get the most value, and they were the people that were in the top third. They were actually on the other side. They were the ones that weren't using it because they'd already come up with innovative things. And it was your less savvy folks that got the most value add from it. So I thought it's a really fascinating result that you need to just understand when you're bringing these new tools into your organization for the first time.
Yeah, absolutely. And I think oftentimes you don't always know, right? And that's part of like getting a lot of these tools. And some of this is making sure you're picking the right specialties, the right use cases, right? And all of that kind of coming together to figure out, okay, who is this really going to benefit? And making sure that you're rolling out technologies in a way that, you're kind of maximizing that value instead of, I think that's some of the challenge with, we were talking about pilots, it's like you can't just scale that value across your institution. You really need to understand, where that impact is going to be.
Right. All right. I'm going to shift gears here for the final 7 minutes. Some really, really exciting questions coming up here. So I've been promoting Rebecca Welling as the VP of Risk Adjustment in Intermountain Health, which is true, but I haven't been completely truthful with all of you. She's also sort of a VC in disguise. She sits on Intermountain's investment committee. And so, Rebecca, if I could have you kind of switch hats and put your investment committee strategist hat on, I'd love for us to talk about the future and the future state of and when I mean future, I don't mean like 2 years down the road. I mean like 12 months down the road, 18 months down the road. Things are moving fast, right? So what types of AI innovation are catching your attention right now as we sit here that you think is going to be worthy of rolling out over the next sort of 6 to 18 months, even if it's just in a pilot phase?
Sure. So we actually have looked at multiple platforms that are coming out. So it's one of my favorite parts of my job is I get to see all the new stuff that's coming and have a voice into what we want to adopt. And normally we're looking for disruptors, things, that are going to really kind of shake up healthcare, because we believe that's what's happening with AI already. And we don't want to be wedded to a solution that solves one problem in a narrow way. We want to pick solutions that are pretty bold and that have lots of potential. So I think that probably goes without saying, but I know for us, we've been looking at things around clinical labs, being able to aggregate all the lab data that a member has to, or a patient has, to be able to say, you know, where is this leading? What does it look like over the last 5 years? What don't we know? And have that AI actually look in and say, here's the clinical indicators, and here's things that are happening that you may not be aware of just looking at each lab. We're looking at things for one of the biggest ones coming on.
I'm sorry, so that, Rebecca, so that lab concept is very similar to what Shaker was looking at for radiology, right? So it's allowing the clinician to have a little bit of a head start into triaging things, or maybe the tech.
Correct. And for Shaker, we are also looking at the radiology as well, to have AI read the radiology and you know, point out emerging trends. We're also looking at clinical registries, using AI in our clinical registries, to be able to track outcomes there, to support research, quality improvement, public health. So we're using AI in those capacities as well. We're also, we've partnered with for appeals. I think I've mentioned that before. Aggregate physician data. We've got so much physician data in a large organization like ours that we're able to now start using. We want to find solutions that actually aggregate what their outcomes are, what their you know, kind of their specialties are, what we're seeing coming from all of these physicians.
For navigation, or for squeezing networks out completely?
Both. A little bit of both. A little bit of both. If we're able to identify in our data that we've got someone in our network that may not be giving really high quality care, and here's, you know, outcomes that we're seeing that are very specific to that provider, then we want to know that in advance.
Now, can I ask you a question? Because I know everyone's thinking, all right, and I don't want to start naming names, but there's a lot of what I would call clinical navigation companies. You know, sort of Castlight was the big one, right?
Right.
How is this different? Or is it?
You know, I don't know. We're still looking.
Okay.
We're still looking to say, okay, how much can we use in, you know, in addition to what Castlight already did? So all of this is things that are kind of ruminating, but I can't say that I can give you pointings to new products that this is happening with, but it's what we're looking at.
Great. Anything else that we're good?
I think we're good.
All right, awesome. I'm going to keep you on the hot seat for a second. Then I'm going to bring in Andrew and Shaker. Will end with you because we'll try to be quick here. When you're evaluating these investments, not so much with you, I'm going to bring you back to your other role now, your RA role, okay? So when you're looking at a solution provider and you're looking at to partner with them and you're thinking about the pricing model, do you break it down on a PMPM basis or some other ROI metric? Maybe.
Yeah. So normally we'll break it down to a PMPM basis and then compare that against the ROI. With a lot of our vendors, because we're, you know, kind of new in the market, they're kind of new in the market, we're helping them. We will do contingency, meaning you have to put some skin in the game too. So if we're going to pilot this product with you at the end of the, you know, the time period that we've designated, there's got to be an ROI there. And this is, you know, a threshold. It's a, you know, 2-to-1 ROI. If we don't get that, then that goes right into, you know, whether we move forward on the pilot. On the investment side, some of these products we're looking at, we don't actually even pilot. We will put money into them and let them work with other organizations.
Okay, so you'll invest in them as a company, as a VC.
Right. Yeah.
Got it. Andrew, what about for you guys? Are you doing PMPM? What ROI impact, PGs, upside downs? Like, give the group listening some guidance on how to go about partnering.
Yeah, sure. Yeah, the pricing model is on a PMPM basis, and yes, like other groups, we are able to demonstrate not only those leading indicators that we talked about through engagement otherwise, but also the ROI, right? The lagging indicator piece. What does that RAF look like? What does that mean to your organization based on the portfolio of risk that you're managing? We help our partners with that.
Great. Shaker, how about Atlanta? How are you going about bringing in these new technologies and trying to manage your risk without, you know, without obviously putting the solution provider in an unfair advantage?
Yeah, and I mean, one of the things that we're starting to do a lot more of is shifting a lot more to like outcomes, right? And in terms of how we're doing pricing models and those kind of things versus I think traditionally the more like the consumption based kind of models that were there, to be able to kind of so that I mean as Rebecca was talking about, really kind of having that skin in the game, where especially for a lot of these early stage companies and those kind of things where it's like as we're looking at kind of innovating and looking at kind of new opportunities, it's how do we make sure that there's a tangible ROI at the end of the day, which is somewhat challenging because a lot of these end up being not immediate ROI, but more long term, especially when we're looking at like
3 years
and those kind of things. So it's like, how do we kind of project that out? How do we look at our, kind of lead and lag measures so that we understand our lag measure, but it's going to take some time. But how do we understand kind of where we're going to measure success with some of those lead measures?
Great. Thank you, all of you. I want to get people to the 1 o'clock. Thank you all who are listening. Really appreciate you tuning in. We do not take the time you spend with us for granted. We hope you use the ideas that Bright Spots shared today to inspire your thinking and enhance your organization's current approach to improving healthcare for all of us. Thank you to our incredible panel, Andrew, Rebecca, Shaker, and to all of you listening. We produce this show each and every week for you. Remember, this is your Bright Spots in Healthcare podcast. Take care, everyone.